Hi, Doug Dormer here with White Pine Systems, and today I want to talk to you about something new and pretty exciting in the world of healthcare called the Accountable Health Communities Model. Now, before we get into the details, I'd like to provide a little context and background. This is a part of a series of video clips and blog posts we've prepared over the last several months, particularly in the summer through till the fall, right up to the election, under the broad heading of Thoughts on the Healthcare Revolution. We produced a Chapter 1 called The Big Divide with 6 episodes talking about the healthcare roadmap, where we've been, where we were then, which is a state of transition, and where we thought we might be going, assuming some continuity in the Affordable Care Act and that general direction. We plan to start Chapter 2, Show Me the Money, talking about the financial models, particularly those that go into effect and are going into effect in 2017 and over the next couple of years. But given the election, the outcome of the election, we published only one video clip on November 9th. It was a Wednesday, you might recall. And the theme of that was we're now entering a period of uncertainty. We don't know what will happen, so we will resume these when we have something to tell you. Well, today we do have something to tell you. We don't know with any more certainty what will happen. We certainly know that repeal is not on the table today, but that doesn't mean it won't be. We don't know if the administration will stop funding the subsidies to the insurance companies, so there's still an awful lot of uncertainty. But in the midst of that uncertainty, under the covers, flying under the clouds, if you will, are new exciting opportunities, one of which is the Accountable Health Communities Model. So what is the Accountable Health Communities Model? It's designed to address the gap in current delivery system by funding interventions that connect community dwelling beneficiaries with community services. I smile when I read that. What does that mean? Well, let's see if we can break it down and figure it out. Going back from the history of our company, back 10 years, we have focused on this same notion expressed a bit differently. When you look at the greatest costs in our healthcare system, they are for adults with chronic medical health conditions. Within that population, those with mental health conditions, particularly with addiction, have the highest cost and the worst outcomes over time. Add to that those that have challenges with basic social supports, whether it's food or housing or transportation or childcare or involvement with the criminal justice system. That's the sweet spot. That's the spot where we can have the greatest impact at the least cost. And so the Accountable Health Communities Model says, let's focus on navigation and coordination as a first step. One of the award recipients used the phrase, it's like they're dipping their toe in their water and they're not quite sure they're ready to get all wet just yet. So it's not a fully mature model, but it's a good start. The problem is that we have built a system of silos between physical health and behavioral health, separate from social supports and criminal justice, that make ours a particularly inefficient system, ranked very low in efficiency, ranked around number 37 in terms of health outcomes. Now, we chose this image to kind of express this homelessness image up in the top, but perhaps a more appropriate representation from the clinician's point of view is expressed by this particular image. So now we have Center for Medicare and Medicaid Services last year under the Affordable Care Act publishing a Funding Opportunity Announcement, FOA, for the Accountable Health Communities. That announcement discusses 3 tracks or 3 measures of intervention. The first is simply awareness. If we make people aware that these services are there, will that have an impact on their utilization of those services and a consequential impact of lowering our costs and improving outcomes? A reasonable question. Track 2 follows the same thread, but says, maybe just telling them and making them aware might not be as powerful as helping people actually coordinate and make that connection. So it's got a navigator model in it to actually help you coordinate to make that introduction. Track 3 says, let's go further. Let's align our services. Let's coordinate. Let's harmonize our services so that we can truly test the thesis that can we, by coordination, by awareness, assistance, and alignment, can we achieve the quadruple aim of improved personal experience, improved population health, lower total cost, and improved clinician and social service provider experience. Now, implicit in that are some really interesting challenges for reporting and some other considerations. So those are the things I want to talk about as we quickly try to move through this somewhat complex discussion. Now, the accountable health communities model includes this rendering, which we rather like. Notice on the top you have all of the healthcare providers. On the bottom you have the social services kinds of providers. You have in the middle the bridge organization, the term they use for the person or the organization that will coordinate and fill that gap. Now, one of the things that strikes me about this is, where do you see the patient or the patient's family or peers? You see them coming through each of the provider organizations. You don't see them participating, although it's certainly implicit that they are, in the social service organizations. And you don't see a clear role for the individual in the bridge organization. Now that stands. Here's our version of that same view of the world. Just as with the accountable health communities model, we have our healthcare providers at the top of the image, including accountable care organizations as well as health information exchanges. And we have social supports at the bottom of the image, including criminal justice, employment, but also adding in personal health records and even devices like glucometers and blood pressure cuffs and home monitoring tools. What also varies slightly in our model is that we hold the patients and consumers and the families and caregivers as equal participants in this model. And at the center of it, we view the Community Engagement Center. So that's our version of the same thing they call the bridging organization. Behind this is what we call the collaboration wheel. This is kind of our theory of how all of this fits together. So each of these wedges in this wheel, between the spokes, represents what we call a care unit. So a care unit could be a chronic physical condition like diabetes or COPD, or pregnancy, or addiction, or mental health. Or it could be a social support like employment or criminal justice. And what we then would look at is, how do we coordinate across the community, both patient engagement and community care collaboration, where the objectives are communication, harmonization, consolidation, and simplicity. Very much what the funding opportunity announcement describes in their term, alignment. And where we describe key attributes, which is to say our care unit approach, a model for approaching each of these wedges, built upon established evidence-based practice and focusing on a behavioral medicine approach, an integrated approach with care collaboration at the heart, with population health as a key driver, and with operating efficiency and performance for providers as the underlying linchpin. From a technology point of view, and I'm not going to spend much time on it, know that we have a series of design tools that overlay onto the SPINN database that support interoperability with electronic health records, health information exchanges, and other systems that generate the user interface. So when I show you these solutions from the user point of view, these are all run on the same application. They're just different expressions, different widgets, different variations of that same thing, all on one set of applications that support reporting and analytics for both internal and external uses. Now, when we talk about this kind of technology, we're really thinking in terms of specific tools that are all brought together, whether it's a form building tool that allows for online and mobile forms and questionnaires, whether they're a screening tool or an assessment tool or an in-depth interview tool or a further ongoing encounter kind of a tool. They're all just form tools that are used to capture information, whether entered by the patient, or in this case it's called the beneficiary, whether by the provider, in this case called the navigator, all built on a similar set of tools. Adding in text and email-based reminders with various kinds of confirmation. Did you do the thing you said you were going to do, so we can track adherence and performance? With question and response, so that we can determine how the individual is doing, so that we can, without investing labor, identify when the patient is at risk at the earliest possible time. Along with social engagement tools, which frankly aren't required for this particular project, but I think may over time. All built around the notion of care units, with supporting reporting and analytics for alternative payment models and indeed the kinds of comparative analytics that we're looking for the accountable health communities model. We also then need to support this, some combination, maybe not all, of portals for patients, clinicians, peers, and social service providers, all of which needs to meet requirements, including, for example, meaningful use stage 2. Those are the requirements that would apply for this kind of patient engagement and care collaboration. And of course, then we may need to support a personal health record. Some of the organizations we've talked to are leaning towards a personal health record as a part of this implementation. Others not so much. Underpinning all of this is what we call the care unit method. These are configurable modules designed for the specific health interests of different health concerns, built around evidence-based practice. So some of those that we've had most success with are substance use disorder, which, by the way, the evidence-based practice is called the recovery-oriented system of care, hence the term EROSC you see here, along with other behavioral health disorders, an e-health coach based on some work we did with the CDC focusing on behavioral medicine, some work we've done focusing on criminal justice and re-entry, one of the major areas of social supports, as well as employment services and pregnancy. We've focused on a particular model with a continuum of care that is not unique, but is very focused on these aspects and leading to continuous improvement along the way. We've seen demonstrated results with a reduction in relapse and rehospitalization, particularly for people in addiction programs. We've seen a decreased rate of recidivism, getting back involved with criminal justice, even though that wasn't the initial intended focus. We've seen increased operational efficiency and financial performance, and certainly we've seen compliance with new and improved reporting metrics, including those that are required for this particular program. So let's look at the 3 tracks in the Accountable Health Communities model. Let's begin by looking at track 1, the awareness intervention. This is pretty straightforward. There are really only 4 steps that are needed. The first is a community resource page, an inventory, someplace people, whether it's a provider or possibly in some models the beneficiary, him or herself, can go to find out what resources are available across the community. The second is some means of registration, whether it's the healthcare provider, the social services provider, or the beneficiary or his or her representative. Third is a screening tool, which not only identifies a health-related social need, but also will help us stratify that risk based on emergency department usage over the last 12 months. And the output from this first track is a tailored community referral summary. Essentially, for that health-related need, here are the instructions for how you can go forward. Under this track, that completes the obligation for track 1. Here's an example of that where we've put in place a link from a client's web page using resources that then brings up a list of those resources, that resources inventory, each of which can be linked to the individual page or to supplemental pages that might have information about how to find it, hours of operation, things of that sort. You can filter this by county or whatever the designation you want, in this case by county. You can organize it by priorities, in this case by type of health need. And we've added in a means so that people can quickly click on this link and open up a form tool to say, here's a new resource you should add to this list. Now, all of this can be maintained by the clinical staff. It doesn't require an IT expert to use the content management system that exists behind this. Next, we need to consider the registration mechanism. Here's a simple registration form that we put together for one of our clients. The key to this is that we can define the role for this person logging in. So whether this person is a physical health provider, a behavioral health provider, a social services provider, or a patient, we should be able to use one registration screen and then assign a role and perhaps even allow them to be promoted within roles. There are a number of things that are important. One, you can link this to an underlying database, whether it's the electronic health record or whether it's a health information exchange. You can, as you can see down at the bottom, put in a master patient index so that we can track that person and identify them by an already established number. You can put in various information to determine, does this person have a cell phone? Do they wish to have reminders sent to them? Daily, weekly, before each event, 5 minutes. What do they wish to have? What's their preference? Email, text, both. We can determine which programs or modules we wish to offer them. Not all of these might apply in this case. We also need to consider seriously how we will document their understanding of the terms and conditions of the services we provide. In this example, one for the use of a patient portal for the recovery-oriented system of care, and also a separate authorization to receive and participate in text messaging. In this case, because the individual has not previously been validated and set up with an account on the system, the method of documenting that evidence is by printing off the two policies, having the beneficiary sign it, and then the navigator or the clinician clicks the box to say the signed terms of conditions has been received from the beneficiary, or the signed text messaging authorization has been received. Now, these processes vary, so my goal here is simply to say even the simple track 1 referral has a need to get the patient to acknowledge the terms and conditions and ultimately to say, yes, I accept this referral and this service from the provider. Now, when it comes to the screening tool, the Center for Medicare and Medicaid Services stipulates exactly what questions must be used in the screening tool. This is an example of a similar tool from our SPINN form tool. SPINN, by the way, means the Secure Personal Information and Notification Network. It is the platform that we are describing. It includes the ability to define domains, and there are several domains in the CMS screening tool. And then by clicking on a given domain, one can open up that domain and see the appropriate questions and answer those individual questions. The green check marks, which you see here, indicate that that section, that domain, has been answered. If it hadn't been, you would see a round circle with an exclamation mark in it to create a quick visual recognition of sections that are not complete. It also lets you create new versions of the screening tool. So you can rescreen and you can set a new due date. And with that new date, you can trigger reminders to say, by the way, we would like you to complete this. So whether the screening tool is done by the navigator or done by the individual, whether it's on a tablet in the lobby of the provider's clinic, or whether it's from home, or whether it's on an iPhone or in the local library, it doesn't matter. We can accommodate that range of solution sets for both the original and the rescreening and keep track of all of that data. Now, one of the things that we've completed the screening tool, we need to get to a tailored community referral summary. That's the piece of paper that we would give to someone and that we may transmit to them in track 3 in an electronic fashion. So this is an example using our form tool the SPINN form tool, to create the referral summary. In this case, we might see the results from the domains in the screening tool transferred to the referral summary, something that the FOA requests, along with the domains and the results along the way. Within each of those domains in the plan, in this case configured as a referral summary, we might see the detailed questions from the screen so that someone can not only see how did they do broadly for the domain, but specifically how did they do, how did they score within the questions that were there. Now in this case, this is more than a simple referral summary, but it gives you an idea. We can say, what is it you have access to? What resources do you have? What problem or risk do you face? So that we want to engage the patient or the beneficiary in expressing what is the problem, what are the assets, what is my goal. Then we can assign tasks. I need to make an appointment at this agency, or I need to do something in preparation of it. So we can, in the referral summary, actually help the individual define the tasks that he or she needs to do, assess how far they are along in that process, and then be able to print this along with the appropriate directions and referral information. That completed the objectives for track 1. Now let's look at track 2, which assumes a continuing role from a navigator to support that referral. In this case, we include an in-depth personal interview. Now the FOA does not describe exactly how you need to do that. It could be an informal kind of a discussion. It could be a formal questionnaire or a combination of a structured data with open-ended questions. One way might be, we think, to use what's called the Behavioral Risk Factors Surveillance System, perhaps along with some readiness rulers, but that's just one approach one might use, because we think it's important in the in-depth personal interview to have enough consistency and to capture data that we can use to measure and to evaluate over time, both from an individual and from a population view. We also need to have a patient-centered action plan. So if the referral summary is a very simple action plan, here's the information to go and make a connection, this one might have more detail with more health needs, more ways in which we will collaborate with you and support you on your journey to address these social needs. Then we need to have follow-up services. How do we document that we are staying in touch with the individual as he or she pursues the actions of the action plan? And finally, how do we document subsequent meetings and encounters with each of the beneficiaries receiving the navigation services? So the first question we would have to deal with is, what do we need to support the in-depth interview? By that, is it a form, a questionnaire? Is it an open structured document on which we take notes? Some of our clients are suggesting that something like this, which we've used in the past, based on the Behavioral Risk Factors Surveillance System, something many of you will have seen, more of a population health tool that we've kind of reverse engineered a little bit to look at the social determinants of health for an individual. Here, by the way, you can see the red circles with the white exclamation mark that signify that these sections have not been completed. Notice also that this questionnaire might include readiness rulers. How important is it for you to make this change? How confident are you can make this change? How timely is it for you to make this change? Or will you do it now? So this is one example. We can also add it in free note sections as well. But we like to recommend something like this because it lets us have a foundation for scoring and for evaluation and serve as an assessment tool that is more in-depth than the screening tool, so we can evaluate individual and population progress over time. Then we have the action plan for track 2. This is a more detailed plan than the referral summary, and we thought we would use one example here, which focuses first on, again, presenting the questions from the assessment tool, in this case the behavioral risk factor surveillance system, then setting forth what are the goals, why do I want to make this change to help reinforce the patient, the beneficiary, some things that could help me with my plan are, what are the assets I have that will help me with it? Then some things that could help me with it. Following that, we would say, what are the specific tasks that I need to accomplish in order to achieve this goal? And then we can go forward from there. What are some of the barriers? Who are other people who could help me? I hope my plan will have these positive results. And I know my plan will be working when. So different models, but in this case, a version of that same SPINN form tool configured as an action plan, as opposed to something like a simpler plan or a referral summary. When it comes to the encounters, again, we think some kind of structure is appropriate. One of the ways we've done this is in the case of addiction, using something called a telephone monitoring and adaptive counseling tool developed by McKay and Company. So here we're again looking at domains. It's not quite the same as an assessment. It's more of a progressive statement based on right now, what am I doing with respect to risky behaviors, with respect to safe behaviors. And we'll see how that can translate into some benefits when we look at the use of this data. This takes us to a dashboard for the navigator, to be able to see what the present status is of an individual as he or she progresses over time. In this case, we're using that encounter tool called, in this model, in our past model, the telephone monitoring and adaptive counseling tool, but it could be any encounter monitoring device. And the graph shows the red line, risky factors, the blue line, protective factors, and the green line shows a net position over time. So we can see, for example, that not long ago this person struggled and reached a kind of a reversal in their progression. Knowing that information for a navigator might be hugely valuable. We can also see the summary results from the most recent encounter questionnaire. We can see the results of the last several. And we can also then from there say, now let me schedule my next meeting, my next encounter. By clicking on that icon, it brings up a schedule. This can either be posted to the calendars for the navigator, for the social services provider, as well as for the beneficiary. If the beneficiary doesn't have a portal, which in some models that's the prevailing thought, not to give the beneficiary access to a website per se, it can still be used to create text-based reminders and text-based confirmation. So the use of the tool can vary, but the underlying benefit of having reminders and text alerts and documentation of that is still fully available. Now, as I say, the calendar is central to it, although not every organization says they wish to make a calendar available to their beneficiaries. In this case, we're seeing a calendar that shows various events. Events in the future just are plain. Events from the past. For each event, you can say, was this completed or not completed? And that can be done via text message. So 20 minutes after the item, the beneficiary gets a text. Did you make the appointment? Did you do the task? Is it complete? Is it not complete? And then we can see quickly, when you have a calendar full of such events, you can see how well that individual is doing, and you've captured raw data for the adherence component. Which brings us to track 3, alignment intervention. Now, the FOA describes track 3 as components of both tracks 1 and track 2, adding structural supports and financial sustainability planning. That's another one of those phrases that is good on a conceptual level, but we struggle with exactly what do we need to accomplish that. A little bit later in the FOA, it gives us some guidance when it says it includes a detailed analysis of how interventions impact the resolution of identified health-related social needs, total health care costs, and inpatient and outpatient health care utilization, both at the overall community level and at the beneficiary level. Boy, that gives us a lot more clarity. Not specificity, but clarity. Really looking at an analysis of how the intervention actually impacts the resolution of the health-related social needs and how that in turn affects total cost and healthcare utilization. Once again, back to that quadruple aim we started with. Drilling into a bit, we think there are 5 areas that might be considered components of alignment intervention. Now, I will tell you, having talked to several organizations, the range of how the organizations intend to address this varies. So not all 5 are included in each organization's plan, nor do they necessarily need to be. But it's worth considering that range. Certainly all organizations will consider at least the first 3 elements. So when we talk about the first, data sharing, really we've got to think in terms of 3 kinds of exchange of information. The first is standards-based, meaning that which is used under meaningful use, including the standard definitions of personal health information that's used by covered entities as defined under HIPAA. It might also include non-standards-based or diverging standards, even in some cases including behavioral health and addiction, but certainly including some of the social services that may have an electronic management record that warrants integration, but it's not going to comply with a HIPAA-based meaningful use kind of standard. And finally, we need to think about direct access, role-based sharing, perhaps of the data that is within the system, as well as secure messaging for those organizations that simply aren't in a position to share electronically data sets. With that, then we have to look at what kind of data analysis and quality improvement planning are we thinking about. Certainly we need to have queries and evidence from the beneficiaries. Did you do the thing you said you were going to do? So we're not just saying we made a referral, now we'll check back and see what the outcome is. In this track 3, we've got to find some way of asking, are we in alignment? And that means, is the beneficiary actually doing something? And how is it working? What is the outcome for you, the beneficiary? We also have to support the in-depth interviews and assessments. And we might here, even if we might choose to go a little more informally in track 2, in track 3, there's a real case to be made for a fairly formal in-depth interview or assessment process that lets us capture data that we can use to measure the alignment process as we strive to achieve that goal. And similarly, we need to have queries and questions and responses for providers, whether it's through the extraction of the data in a standard format or whether it's through a specific query or a combination of both. So the kinds of forms and processes also needed to be included. And of course, we have to consider all of it based on evidence-based practice appropriate to that sub-intervention. Sub-intervention meaning either healthcare or for a health-related social need. There needs to be some focus on what is the evidence-based practice. Is it a per occurrence self-contained episode, or is it something like employment or criminal justice reentry that extends over a period of time and has a more formalized process to which we need to address the question of fidelity, sticking to that practice and documenting it over time. Now, financial analysis is, of course, hugely important. I'm a little reluctant to go too deeply into it here. People may do it through their own applications. They may have application tools, spreadsheets. We certainly look for opportunities where we can incorporate the same kinds of things, incorporating the data from CMS, incorporating the data directly from the behavioral health providers so that we can begin to capture some information about costs in total and then analyze that following methods not all that dissimilar from what we're seeing for the clinical side of the application. Patient engagement is an interesting area in my discussions with several organizations. To what extent does the patient need to be involved as an active participant? Again, go back to the rendering of the image of the bridge organization, and it looks like there's not a direct seat at the table for the patient. On the other hand, other organizations are saying we really need to document more clearly and indeed perhaps go all the way through to a personal health record when we include a full range of information. That lets us manage some of the permissions that need to be in place for such things as disclosure of information, personal health information, particularly around addiction and some of the tricky areas. And finally, there's no indication in here of social community engagement, social media, trying to reach out, trying to engage people in groups or in collaboration with each other. We think those are opportunities to expand, but again, depending on the organization, they may play a greater or a lesser role. Now, there is prescribed a certain amount of basic demographic information relating to insurance, relating to episodes and care plans, and so that's pretty standard stuff. But in some organizations, it's going quite a bit further. Some organizations are talking about really a full suite of patient information data sets, including medications, problems, allergies, immunizations, lab results, as well as encounters and discharge plans and treatment plans. So certainly we can support that, but now we get into not a technology question as much as into a workflow and a legal kind of a question, again referring back to particularly addiction, which falls under the set of federal regulations referred to as 42 CFR Part 2. Now we're into the question of consent to sharing information and managing some of those issues. Now, one of our clients has specifically asked us, can we upload the information electronically from an electronic health record using some of the standard formats like the continuity of care document? Certainly we can do that. We can upload it. In some cases, there's a need to transform it. I'll skip the details for now. We can print summaries of that information so people can carry a hard copy or have a wallet card that may have relevant information for a near-term circumstance. We even have an emergency notification routine that we'll skip in today's discussion but may come in handy. We can also upload specific files and even authorize the sharing of information particularly if it's structured as a personal health record. Again, questions beyond the scope for today's discussion. If we're going to do that, we also need to consider a secure message system. Now, if your organization has a secure message system that can be used to share information, including that from partners such as social services organizations, community social support agencies, by all means, let's use that. But if not, then we have this secure messaging system we can include. Now, the difference between a secure messaging center and for email, for example, and there are several approaches, this is just one, is that you have to make, in this case, no, you're not really moving the data. The data resides in a place, and so someone can securely view the data and interact with the data to receive messages, to originate messages, to respond and prioritize messages. This has a handy aspect in that we can capture data about who originated a referral, when that referral occurred, and by a quick scan, we can see those that remain bolded, which means no one has opened that message. We can see, has the receiving organization opened or acknowledged that referral. Furthermore, within that, we can also run a report against that data saying, here are the ones that have received, here are the ones that haven't, here's the average time to open up and to view that referral. So a secure message center is going to be a key part of this workflow, wherever it comes from. We also need to think, if we're going to engage the patients, something we've done where these are various screens that can be used in either a mobile or an online scenario with a daily calendar. We talked about that earlier. We can also talk about prioritizing goals so that we can help someone see the goals, click on that bar, open up the bar, and see what tasks I have to do, click completion, get some gratification right from the application that says, yes, I have achieved that. Maybe confetti and balloons is the model that I tend to prefer myself. But the idea is to determine what level of interaction we want with the patient, and then to allow that to be supported without it being labor intensive. Now we get to the question of reporting. As I said, I think that when it comes to track 3, they've given us general guidance, but a lot of latitude about how to accomplish those objectives, and they expect that each organization will work that through and seek approval with CMS and then be able to follow its own course. The result being that out of the 32 organizations and the 20 that are on track 3 in particular, that we'll see some benefit, some patterns from the variation that will lead us to broader recommendations in the future. So here are a few, not to say that these are the be-all and end-all or even designed specifically for this, But these are the kinds of things we've done that might be applicable depending upon the approach by each organization. In this case, we're using the telephone monitoring and adaptive counseling tool. So that's sort of a tool that fills the encounter need. How are you doing? Not so much as an assessment, but in your progress. And so it measures protective factors and risk factors to get to an average progression over time. This then represents a population of people, no matter when they start, over the milestones we've designed for that particular interaction. This is an interesting example of that report, that graph we just looked at for a population of people using the telephone monitoring and adaptive counseling tool in support of substance use disorder. In the second half of 2013, we went live with one of our clients, and we could see a pattern that at milestone 5, there was a clear dip, a dip in the use of protective behaviors, an increase in risky behaviors, and a huge drop in overall pattern. We could see that that crossed all demographic patterns and all age groups. And so we went to our client and said, what's going on here? Can you tell us what it is? And they said essentially, oh yeah, we see what that is. We know what that is. That's the point at which the individuals realize that this is a life-changing behavior and they're coming to terms with it, that they have to make this change, realizing that they still live in the same environment, the same community, the same influences that they've always had. And so we spoke to them and said, how do we change the intervention? And the solution came from the individuals that were the coaches and the clinicians, in this case the navigators, that said, let's increase the level of engagement with our beneficiaries. And then 6 months later, you can see the result here, a significant improvement in those reports. Now, what's significant in our discussion with the client on this is they said, right away, we know what this is, but then they said, but we've never seen it before. So we have an opportunity to really capture new and exciting information in support of this Track 3 intervention. Of course, we can also take a look at an assessment. We could use, this is using the recovery capital scale, one of the ones we really like. It could also be used for the behavioral risk factors surveillance system, which we talked about earlier, or for any others. And we can not only compare then our population at day 1 and our population 6 months later, and for example, and then be able to look at the effectiveness of the change. So graphic representations, tabular presentations, all to gain greater insight, just as requested by the FOA. We can also track basics. How are we doing in terms of the number of new people added each month? What's our cumulative number of people over time? We can track duration, or perhaps the time until an account is closed or deemed open, still active, completed and resolved, or failed and not completed, or not achieving the objective. So these kinds of things that relate to time are critically important in the question of that correlation between the use of these services and the effect of overall cost and satisfaction, again, the quadruple aim. And of course, we have to have some measures that focus on the clinical side. What is the effect on our clinical usage? Now, the root measure that we find in many cases is the number of patients per clinician. If we can actually improve efficiency or reduce the need for the number of interventions, number of encounters rather, for clinical purposes, then we really are beginning to increase the efficiency and utilization as well as outcomes. In this case, we might take several instances and say, from the viewing the navigators, how many of them have we completed the in-depth interview? How many of them have we completed the action plan? How many of them have we completed a specified number of encounters? You can see there are a number of ways we can do this, either in aggregate or by looking at individual navigators. Now, on the financial analysis side, it's a tricky kind of an area, and there are, as I say, many ways one can go at it, whether it's within a separate system or without. We'd love to include it in our systems. We've got to be able to import data from CMS. We've got to import data from state and local agencies. In the absence of getting it from CMS, we've got to be able to get data from other agencies that are not included in CMS to be able to determine total cost, the FOA, from the discussions I've had with folks, is the interpretations are not all quite the same, whether or not people need to include costs from the community services agencies. That may vary. The main thing is to focus on the healthcare costs through Medicaid or CMS. One of the interesting things we ask is, what benchmark data do you have to work with? Now, benchmark data is pretty easy in terms of the Medicare side of it, Medicaid side of it. You can get that data for a population and work with it. It becomes more difficult if we want to measure what levels of utilization do we have of these services. So one of the things that we suggest to clients is to use this time while you're putting the system in place to actually begin accumulating data about behaviors. It may not be financial data, but it may be activity-based data for utilization of these services, so that we have not only a financial but a corollary measure of utilization of community service agency services and interventions to be able to measure against. That then lets us establish targets and then set up our own goals so that we can ensure that each organization meets those goals and is positioned for the long run, and ideally for sustainability independent of the FOA and this particular funding program. There are a few other quick considerations I just want to touch on. One, of course, is data ownership. I've kind of skirted around that issue as we've talked about this today. If what you're doing is a basic referral, there's not a lot of data to worry about, and we don't have too much of an issue. If the data is within our record system and we are exposing it to others, whether particularly to other agencies, then the selection of what data is exposed is absolutely critical, as is the construction of a particular form of business associate agreement that lets us go beyond what a traditional healthcare environment might be and look at how we might accomplish that, and then putting the appropriate processes, audit, and documentation pieces in place. We might also realize that if we're going further, we may end up saying it makes sense for us to make this truly patient-centric, create it as a personal health record, which is what's going on in certain of the communities, and then allow the individual to manage the data and the consent to share that information. That gets us past some of the tricky areas of security and privacy, particularly the regulations around addiction, which we referred to as 42 CFR Part 2. Again, social engagement, opportunities to band together organizations and people, whether it's using online tools or in-person tools, I think is a real opportunity. Probably a bridge too far for this particular funding opportunity, but I think it's something to think about that may make sense to increase the levels of participation and achieve the objective of greater involvement of these social services. Finally, when I look at this and as I discuss it with some of the organizations, we ask the question, what's in it for the social services agencies? None of the funding that comes out of this can be used to deliver those services for food or housing or transportation or employment or criminal justice reentry. So what do those agencies get for participating in this? Certainly we must have the money to reimburse them for their labor costs to participate, but what's in it for them? And I think the answer to that is analytics. We have to be able to make sure that while beyond the scope of the FOA, that we think about what can we provide to you, Mr. Social Service Organization Administrator, that helps you improve these same corollary effects in your environment. Who pays your ticket? What do they need to have to demonstrate it? And how can we collaborate with you to provide insights into that? So those are characteristics that will affect the overall design as we move quickly into this implementation phase. Now, in terms of the implementation, assuming a start date of August 1st, assuming any start date, but in this case, we think it makes sense to get started as close as possible to August 1st if you're not already into this. We think that the first step is a clear business and functional requirements analysis. Now, that's different than the kinds of needs assessment that each organization has done to submit their grant application. This is really a business approach to exactly what's the workflow. It's getting all the puppies in the box, getting everybody to sign off with agreement to what we're each going to do to accomplish this. That then establishes the technology requirements, both initial and with some planning for an evolution over time. Next then is the design, integration, and configuration. And in that case, we believe SPINN is an ideal platform, the Secure Personal Information and Notification Network. Typically, that's about a 4-month program. In this case, it also includes contemporaneous, concurrent approvals from CMS of the workflow of the various tools, but we don't see CMS providing any delays. We think it's a very achievable target within 120 days. We see a couple of weeks for training, mainly because we are likely to have so many organizations and schedules will need several sessions to accomplish it. And we need 30 days to test and refine and go further with it in a limited production kind of mode. So we think 6 to 8 months is the ideal time, which makes it ideal for the Track 3 implementation, and I'll say by the skin of our teeth. In other words, we don't have a lot of time to monkey around. We do need to make sure that we, in our planning, have the right resources at each organization to support the kind of development that needs to be done without delays that impact the entire group. Now, in terms of pricing, and I struggled with whether or not we should include this in here, but it's really pretty straightforward. We know what the FOA says. It says that this should be a series of 5 one-year grants, renewable, depending on performance, and depending upon approval of the budget that includes this project beyond the present year, which is funded under the Obama administration. So if, for example, Track 3 is a $4.5 million grant, that means it's about $900,000 per year. And the guidance, as in so many of these federal grants, says 15% can be used for technology and infrastructure, then that means that this part needs to be right around 10% in order to leave a full 5% available for working within each organization to do the complementary sides of all of this work. But making this nonetheless a complete, comprehensive solution, but for interoperability with the various systems and coordination with message systems, etc. So we look at it as quite a simple approach where our focus is to really put in a monthly charge for the duration going forward. Once it's live, a simple 1-month charge that will cover all of the users you need, however many. We know that they're looking for 75,000 screenings per year, all of the users from whatever organization, and includes the evolving product as it works over time, as we add features to it within the scope of this. So it's not a all things to all people all the time inclusion, but it is enough to say we have our collectively, that is to say, our company White Pine Systems, as well as all of the clients that we have working on this, both within the grant program and those using the program under the applications under similar kinds of programs, that there is a natural evolution over time, and we want to make sure that we cover that without having to go back and seek specific approvals. Now, if it's a one-off or something truly unique or amazingly complex, well, we'll have to talk about that. But I think you get the idea. We want to keep this as simple and clean as possible, and yet make it a one-time, 1 year at a time kind of a deal that is that achieves the ROI for each organization within each standalone year, and yet is sufficiently well funded to allow for us to be able to deliver it and support it and configure it and train it. Finally, I thought I'd let you take a look at a nice little video that one of our clients, Centerstone of Indiana, prepared for an event held at the White House. They received recognition from the NIH and from the Substance Abuse and Mental Health Services Administration. Now, to be clear, this isn't the same multi-organizational configuration, but it is multiple departments within one larger organization, Centerstone of Indiana. So the organizations, the divisions that they were including at the time that this was presented included addiction services, criminal justice reentry, employment services, and an e-health coach. Many of the kinds of things we're talking about in this grant were included in this presentation. And so this is just a short 5-minute video. I hope you'll take a moment and watch it and hear what our clients themselves say about this approach and this wonderful work. Well, that's it for now. I thank you very much for taking the time to listen to me and to join me for this presentation. I hope that we'll have a chance to talk again, and I wish you the very best with this important opportunity. Thank you. Goodbye.